Hello everyone, welcome to the webinar and thank you for joining us. Today we're learning about SBIRT in primary care in senior care facilities for older adults at risk for possible substance use disorders and/or depression. Today's webinar is produced in partnership with the BIG Initiative, NORC at the University of Chicago, the National SBIRT ATTC, NADAC, and SAMHSA. Now on your screen, you'll see a listing of our current webinar series. There is a lot of information available on many different topics, and you can go to the link at the bottom to access recordings of these webinars or to sign up for ones still to come in the series. There is also a ton of material available for today's webinar. At the link provided, you will find today's slides. There is also a CE quiz, as free CEs are available for today's webinar. This is where you will find the recording after the fact, available 24/7, and free CEs are available for that as well. This is a great way to watch the content again or to share it with a colleague. Now we will have a question and answer session at the end of the presentation, so please type any questions into the question pane and we will collect these for that time. Our technical facilitator today is Misty Story, Director of Training and Professional Development. She will be handling any technical issues, so please use the question pane to reach out to her with those problems, and she will troubleshoot those with you. Now our presenter today is Dr. Hazlett, and I'd like to give you a background. Dr. Hazlett has 39 years experience in the mental health, behavioral health, and addictions fields. In the last 10 years, he has assisted in SBIRT grant preparation, solicited appropriate provider sites, developed training curricula, and has provided training to physicians, residents, nurses, medical assistants, healthcare educators, and social workers in the area of screening, brief interventions, and treatment for substance misuse, abuse, and dependency. He has successfully implemented the SBIRT Project in hospital emergency rooms, medical centers, urgent care, multi-physician practices, senior care centers, mobile medical, mental health, substance abuse treatment, federally qualified health center, and other social services programs. Now, if you're ready, Dr. Hazlett, I will hand things over to you.
Thank you, Danielle. It's a pleasure to be here. Today we're going to be talking a lot about the older adult population. We were probably the first in the SBIRT projects over the last 10 years, back in 2007, to start it and specifically work with just the older adults. Most of the programs that I've done over the years usually go with 18 and above, but because Florida is such a large retirement community, we decided that we wanted to focus in on that. And one thing that we want to talk a little bit about with the aging population is, and I'm one of those, it was kind of funny when I came down here to Florida. I was 55 years old and moved into a large retirement community. And to consider myself as one of those older adults was kind of funny for me at the very beginning. And even in Florida, we use the term older adults, but we still have organizations at state level, such as the Elder Affairs. So it all depends on the person, on how they like to be described. And one key thing that I know to our aging process, especially for me, is the ability to enjoy ourselves, but mostly to be able to laugh at ourselves. And here's Mildred. She's there, and she's at the buffet line, and she says, turning 50 is like visiting an all-you-can-eat buffet. What should be hot is cold, what should be firm is limp, and you'll notice the buns aren't very fresh. And that's quite true as you grow older. Also, Mildred says, good news, people are living longer than ever, but the bad news is we don't get to choose which people. So anyhow, a little bit of laughter, it goes a long way. So I want today's presentation, I want to be able to address some of the types and extent of the substance use, problems with older adults. To know the population is very important, especially working with young counselors just coming out of school or getting their certificates and beginning to work, and they're starting to work with different populations, and it's really good for them to, especially down here in Florida, to kind of know what kind of issues that the older populations deal with here. Also, I don't know how many of you out there have been working in the SBIRT, the Screening, Brief Intervention, and Referral to Treatment Initiative with Florida, but we're going to be talking just a little bit about that, but also what the BRITE is. The BRITE Project is actually an SBIRT program, but focuses on the older adults 55 and above. We're going to talk about some of the screening tools that go along with that. Also approaches for motivation for them to reduce or change the use of the substances. And all of the information, the screening tools are evidence-based, and we're going to be talking about what is brief advice and intervention. Also, how to implement SBIRT within the aging services. Okay, first, let's take a look at the definition of what the Social Security Administration says is old. Actually, 55 to 64. There are other terminologies they use, elderly, which is 65 to 74. Then the age, 75 to 85, and very old, 85 plus. And that's very hard to tell my next door neighbor here. He's 89 years old and he still golfs. He's very active in the community. So, you know, those are very harsh terms for people to admit to themselves. And there are some other definitions. What young old is, relatively healthy and active, and we have a lot in this community. We have over 110,000 retirees, but there's plenty of golf clubs, our golf courses, swimming pools, aerobics, all kinds of things going on down here. Old is basically they have some disability, decline in functioning. Perhaps they need aids in walking, starting with the canes and then to walkers, wheelchairs, and they may need more assistance. We find that for the older adult population, Florida is kind of increasing those services because of the retirement population that we have here. But in other states, as I've worked in Ohio, Pennsylvania, the services aren't as great as they are here in Florida. Okay, and today's world is just really reasonable when we put labels on the older adult population, because a lot of them are very, very active. They're more active than a lot of the younger people that I knew when I first came down here. You have people in their 70s in the morning at 8 o'clock in water aerobics. You have them on their bicycles with their tight bicycle suits, and 20 to 30 of them going down the road, water volleyball, golf, tennis, pickleball, you name it. It's very active. And but there's a lot of communities that you deal with, and we still deal with out here that in Florida that are not that way. But the problem that we have with older adults is basically they're underserved. And as you can see, few services throughout the United States for older adults 55 and plus results in about approximately 5 persons receiving services for every 100 who is in need of service. Older adults don't seek service in social service settings. They're not going to walk into your social service agency or into your drug and alcohol program and say, I'd like to be assessed for my use of prescription drugs or whatever. But they will go to their physician, and we're going to talk about how important that is to initiate this program into the primary care services for older adults. The barriers for older adults face are basically unique to their population, and you can find a lot of this information on the Center for Disease Control and Prevention. Also, if you're familiar with DAWN, Drug and Alcohol Warning Network. Here you have the State of Health and Aging in America. And also SAMHSA has information. But a lot of times, even on SAMHSA, as we look, a lot of the information is not up to date because there's not a whole lot of information and research going on with the older adult population. Also, there's some national trends of seniors, as they say, from the U.S. Census Bureau, because people are being more active and more concerned about their health as they grow older. Americans 65 and older will double in the next 25 years. By 2030, you're going to see 72 million people that will be 65 years or older. That's close to 1 out of every 5 Americans. Also, by 2050, you'll see how they will approach 90 million. 65 and older, 85 and older, and 100 and older will increase over the next 40 years at an alarming rate. A lot of the people that I know down here that are my age, this year I just turned 65. When I came down here I was 55. There are people in their 70s, 75, 80 that I see out in the tennis court that can probably whip my butt right now. So it's, again, like I say, because of that, people are living much longer, and we need to deal with that with our services that we have in our communities. As you see, more patients 65 and older are admitted to hospitals for alcohol-connected problems than for heart attacks. About a quarter of the nursing home admissions occur because patients are unable to manage their medications. And psychoactive drug use, particularly among patients 65 or older, the rate increased 89.2% from 2005 to 2009 among this age group. That's really important. Most of all your drug programs and your screenings way before we started SBIRT back in 2003, most of them are concerned about their abuse of alcohol and addictive drugs. And no one was really talking about misuse of prescription medication, over-the-counter drugs. Those kind of issues weren't being asked. And with our BRITE Project, we kind of focus on those kind of issues because, as you know, older adults, as they get older, sometimes forget to take their medications. It's an issue. Taking the wrong medication because of poor eyesight or some slight dementia, which we're going to be talking more about that a little bit later. Also, barriers cited by older adults is society's negative stereotypes about them. They're often internalized by the older adults themselves, and their lack of awareness by professional society, family, and older adults. Training of clinicians is very important in addictions, but also focusing on the issues that we deal with older adults. I know there's been a lot of focus now on the teenage population. Also, we need to be able to train the clinicians in gerontology, and the application of younger standards to older adults is a barrier because I'll give you an example. One doctor tells me that I'm right under the diabetes line. I've got to cut back on this and I got to do this. And then another doctor that has been trained in geriatrics tells me that's the standard. Your score is a standard for someone much younger than you. You are older, and these are the new standards for the older adults. So as you can see, the one physician wasn't that well trained in working with older adults. And again, since older adults, their population is growing, we need to focus on this kind of services and knowledge. The clinician's behavior, the amount of time spent with patients, sometimes people are really uncomfortable working with older adults because of their lack of knowledge about those kind of issues. Sometimes they're very discomforting about they don't want to raise issues. They see no benefit. Like, he's 85, why should I talk to him about his abuse of alcohol? He may be passing away in a few years, and that's not true. But, this is the way some people perceive things and think about it. Comorbidity, substance use problems mistaken for other problems. Because a lot of people that don't have experience working with older adults see someone very confused or whatever, oh, this person must be suffering from dementia, and they don't look in their wastebasket and they see 2 or 3 empty 12-pack cartons there, or check the refrigerator, you'll find there's more beer in there than there is food. So these kind of things that we try to bring to the attention of people that are working with adults. For example, we've extended SBIRT into the adult protective agencies because they go in for other issues. They need to look in the wastebasket, and when they're checking for food, they need to check how much alcohol and beer is in the house, because it's maybe part of the reason why they're experiencing some of this confusion and they're falling. Falling is another problem. Why is it difficult to identify alcohol and drug problems? With older adults, we know that there is a decreased tolerance with age, and there's still that stigma on part of the older adult. They don't want to admit that they're using the alcohol, especially when they're going through a lot of problems. As you do, as you begin to get older, you start, the losses that you have in your life increase. Your friends, your spouse, and sometimes it's a shame they lose their children. So all these things can affect the adult, the older adult, looking at their alcohol or drug use. Also, living alone, that's one of the big problems. There's no one to observe the older adult. Also, difficulty providing an accurate history. Sometimes it's very difficult. I know my wife here, before she retired, was an assistant nursing director at a large program where you could buy your home, and then you can move into an assisted living, and then from there you move into a nursing home. And she was the assistant nursing director of the nursing home facility as well as the independent. And when they would come in, they do their 24-hour nursing assessment. They find a lot of these older adults are on 20 to 30 different types of medication. So they do an assessment right away, and the physician sometimes reduces their meds where one med could do 3 or 4 things because a lot of times they don't talk to their physicians about the different medications or even the doctors that they visit. Significant others, adult children, their reactions to their parents drinking, they're kind of ashamed. They don't want to let anyone know, and therefore they end up not getting any type of help for their parents. There's common reasons for not helping. Well, he's been drinking all his life. He's too old to change. And we know that's not true, but people still think that way. Drinking is the only pleasure she has left. Why deprive her of one thing that makes her happy? Doctor says the glass of wine in the evening is good for the heart. All these things are reasons why that create people from not getting the kind of help that they do. They need individuals in their life that can be honest with them and focus on the problem. Also, you can see that substance use problems, that's the estimate is that the elder boom unfolds. Like I said, we're growing. The number of older adults with substance use problems will double by 2030. And so we need to have services established so that we can deal with the numbers as well as with the problems that this population faces. Look, this is one of your typical older adults. He worked hard for 45 years, looked forward to retirement. You can see his wife's deceased. He's kind of depressed. His children live 1,000 miles away. They may call him and they may not. Numerous aches and pains, indigestion, medication for nervousness, can't sleep at night, naps during the day, watches TV, and drinks in the afternoon. He drinks more in the evening. He hates getting up in the morning. And as you can see, the alcohol is starting to become a little bit more increasing over the time period, and there needs to be some type of intervention. Also, let's take a look at another person. Here's Mary. This is a typical, example of an older adult. She's 82 years old. Her husband's deceased, lives in senior subsidized high-rise. Social Security check barely provides enough to live on, takes numerous medications, children call each week, long distance, nervous, depressed, gets relief by getting together for girls for cocktails. And these are typical. And as people get older and they experience these losses in their lives and they are alone, not only does their use of need for medication, but also they seek out their own self-medication. So the characteristics of alcohols in old generations, as you look at the American Medical Association and ASAM criteria, you look at generally in the general characteristics of people that abuse, they have an impaired control over drinking, preoccupation with the drug alcohol, continued use in spite of adverse consequences. But as you can see, as it goes into the addiction phase, the onset or continuation of alcohol-related problems, behaviors exist because of psychological and psychosocial changes. And this happens, and it happens very quickly because we talked about earlier about the decrease in their tolerance levels for it, which helps them to cross that invisible line that we have under the psychological over to the physiological dependency on it. Here's some areas that we need to assess older adults, and I'm kind of going kind of fast here. I'm trying to get to some of the key issues here with the SBIRT and BRITE, but I wanted to give you some information about what we're dealing with older adults. And these are some of the areas that every program should be assessing when they were looking for. Look for medical problems. You'll see physical distress, chronic pain, physical insomnia, sensor deficits in vision and hearing, reduced mobility and cognitive impairment and change. And a lot of times when they do these assessments, they don't associate that some of these problems may be created by misusing one or two different types of medication, and especially the other opposite is very true with older adults. The key thing after alcohol is the pain medications. The hydrocodone, the tramadol, all those kinds of synthetic narcotics that are used for dealing with pain. Loratabs. I know someone that I'm working with right now as a friend, trying to get him to look at that because he has chronic back pains and he just takes a Loratab whenever. I mean, I know that he's using more than what he's supposed to, but it's difficult for them to work through that denial. But I continue to keep trying. So also we have older adults and medication use. You can see over 65 use it 3 times much medication as the rest of the population. Older patients average 2 to 3 serious medication errors per month. This happens a lot. One of the biggest ones is they forgot to take their medication. In about 3 hours, they'll take one, the one that they missed, and then in 2 hours, they'll take the one that they were supposed to at that time period. And for those of you that work with medicine, you know that it's okay for your meds if you take it an hour before or an hour after, but you're talking about 3 hours after you were supposed to, and you take one, and then you take one as normal. You can see that they begin to misuse this medication, and they start to have problems. Also, at least 40% don't follow their prescription directions. And one study indicated that this was true for almost 90%. And some of the reasons why seniors often don't take their medications: forgetfulness, concerns about side effects, duration of complexity, lack of information, and concerns about cost. They're supposed to take one tablet, but they'll cut it in half and only take half the tablet. So factors increasing risk of medication: multiple diseases, sensory impairments, language barriers. As they get older, I see it, and even in myself, with backaches, problems, especially since we want to continue to try to be as healthy, and we participate in sports, and sometimes we overdo it. Again, we're not 21 or 22. but it's good that we do some type of exercise, and there needs to be interventions, letting people know what kind of exercise is good for them. And this is really important for doctors to have an understanding of that, so that when the patients come in, when they have an injury, they can talk about that and make recommendations about what type of physical exercise that they can do based on their age. Also, problems intervention with older adults. We talked a little bit about that, all right. Living alone. Significant others may have little information about the problem. Geographical distance for significant others. A lot of, down here, a lot of the children are living, thousands of miles away and not aware of it. Issues. We can continue that. Unwillingness to assist others to participate, lack of adequate reimbursement for treatment, lack of appropriate treatment resources. And that's what we're working on down here in Florida, and hoping that other states are doing the same. A lot of them are taking financial care of the children and also their parents. Issues of possible inheritance. All these kinds of things are factors why the interventions, there's difficult interventions with the older adults. I don't want to lose my inheritance, so I'm not going to say anything to my dad about his drinking. Possible symptoms of depression. We're the only state that started the SBIRT. Actually, not only with substance, we went into the depression. Also, we screened for the depression because we know that's going to be there, especially with the older adult population as they get older. And again, they have so much losses and other issues going on. You see possible persistent sad moods, loss of pleasure, interest in activities, a lot of sleep disturbances in this population, too much little waking, their appetite, you'll see weight changes. These are things that we kind of have to be aware of as we're dealing with this population, especially when they're coming into senior centers for the day, they're coming into retirement communities, partial programs, into their physician's office. Need to be very much aware of these symptoms. Also feeling guilty, hopeless, and worthless, and thoughts of death or suicide. In any one of our fields, not only with the older adult populations, we're very much aware of the suicidal issues, and this with the depression and suicidal risk. Clinically depressed mood is associated with 83% of our elderly suicides with the older adults. And people that have multiple episodes of depression are at greater risk for suicide than those who've had a single episode. I'll give you an example of a person I worked with. They've seen so many people die. They're 93 years old, and their children have expired, and they have no one there. So their depression continues even more so if there isn't any type of intervention and anyone around them that cares. So when they go into, if you have a senior care program or a day program for seniors, when you notice those kinds of signs and symptoms, it would be very great to try to do some type of intervention, which we're going to talk about. Okay. Suicide in older adults, as you can see, the leading cause of suicide among them is depression, and it's often undiagnosed and untreated. But depression a lot of times leads to using medication that they're not supposed to. Somebody will say, well, here, especially older adults share medication. Here, take one of my Valium, it'll help you. But this happens. It's a normal thing for them. The act of completing suicide is really preceded by only one cause or one reason. Especially in the elderly, the common risks are like the recent death of their spouse or a loved one, their physical illnesses. They deal with chronic pain for so long, there's just nothing done about it, and sometimes they say, I'd rather kill myself and live with this pain. Their perceived poor health. These people are very high risk. There's social isolation and loneliness. When you have someone that is isolating from everyone else, that's a sign that there needs to be some kind of intervention being done. Especially that's why adult protective services are called a lot of times into homes where someone has called in and says, I haven't seen Mrs. Johnson for a couple months yet, and she usually is out in her yard, and I'm kind of concerned about her. Out goes an adult protective worker to make a check and find that some of these things are going on in their lives, and hopefully they can get them some help. Major changes in social roles. Older adults are increased risks. 80% of older adults have at least one chronic health condition. 50% have 2 or more chronic health conditions. And depression is more common in people who also have other illnesses. This information you can look at the Center for Disease Control, and you can get further information. I just want to cover a little bit of that. Okay, we're going to be talking about scales for screening older adults. We're going to be talking about, for example, in cognitively intact patients ages 60 plus, we use the Short-Geriatric Depression Scale here in Florida, and I think it's a really good one to use. Some states use the PHQ-9, which is the Patient Health Questionnaire, and I'm going to talk a little bit more about that when I get into the screens. And some others that you can use, other scales, have different mixed results. You have the Beck Depression Inventory for depression, Zung Depression Scale, and patients who have cognitive deficits, the Cornell Scale, or the informant version of the Short-Geriatric Scale, Depression Scale, is being used. And I think this is a very good one to use when you're screening for older adults, and I'll tell you the ones that we specifically use. So in depression, it's common in older adults, and it's a very serious medical problem, and most older adults aren't screened routinely for this. And families don't recognize signs and symptoms. Even though there's a lot of programs on TV to educate, a lot of people don't watch those kind of programs. Most depression goes untreated, and those who do receive treatment are more likely to be treated by their physician than a mental health professional. And sometimes the routine physician, and that's not happening so much in the HMOs anymore. A lot of the HMO physicians, primary physicians, do not like to prescribe any type of psychotropic medications. They like to refer them out to specialists, which in one way is a good thing. So this is about conclusions of the depression. So let's really get into a little bit about the SBIRT, which is a Screening Brief Intervention Referral to Treatment Initiative. It's been around since 2003. Those of you that are out there working in the SBIRT, it's really a great project. It basically was developed for anyone to use. It doesn't have to be a psychologist. You don't have to be a licensed mental health worker to do some of this work. It's really good that you can train people with degrees in education. I have X-ray technicians that are involved in this project, EMTs, NLPs. So this is a great, as a matter of fact, I did some training in Miami with some churches. They wanted to be involved when they talked with the older adults and with the 18 and above, talking about their use of medications and substances. Data from SAMHSA, as you can see, it changes all the time, but we have over 1 million people have been screened across the U.S. for SBIRT through SBIRT sites. It's proven that SBIRT can reduce the use after 6 months. As you can see, 41% of respondents reported abstinence from drugs, alcohol, at follow-up. As in SBIRT, we do the 6-month follow-up, improvement in the quality of life, also reduction in risky behaviors. That's what we want to do with the BRITE. We don't not only want to look for a dependent person, we want to look for people that are misusing it into abuse of the substances. And that's what SBIRT does. Excuse me. There we go. As you can see, SBIRT's initiative is evidence-based, identify persons at all levels, providing brief intervention and what we call extensive brief interventions now. We first used the term brief treatment when we got started, but a lot of people confuse that as being the substance abuse treatment. It was crossing lines. SBIRT is in between that. It's something that can be utilized prior to the person being referred for the traditional substance abuse treatment. It's really great for people that are very ambivalent, that don't want to go into treatment right now, but one of the things that the education specialist or the SBIRT interventionist is doing is getting them ready to go. So screening is very important. We screen all individuals, especially when they come into primary care. So we refer patients who screen at high risk for possible alcohol or other drug dependency. So it reaches all. And as you can see, those are the components of the SBIRT. You can go to SAMHSA and look at those SBIRT core components. So medication misuse, frequent in older adults, is there, and so we need to do something a little bit different. As you can see, you know, he wants the Viagra, but his wife says no. A little bit of humor here. Older adults and medication use, you can see 43.1 million adults age 65 and older in the United States. By 2040 that will increase to 79.7 million. As you can look at these statistics, it will tell you that it is definitely a problem that's growing. So we had to change our approach to substance misuse in older adults, especially here in Florida, and we developed a program called BRITE. We got $14 million here to get started, a 5-year project from 2006 to 2011. It goes to direct services. To give you an example of it, when we first started here, they were about almost a half a year into it, and when I came on board with the state, I said, that's not going to work out. These are 4 contracts that you have with treatment facilities, you know, substance abuse. You need to be in primary care. So that's when I got onto my horse and went throughout Florida and went from 4 contracts to 28 contracts with over 65 sites in the state of Florida providing SBIRT services. We focused on problematic use of people 55 and older. 2010, some agencies began to focus. We got them started on the 18 and above. Involves a multi-site demonstration department of children and families throughout Florida, implemented in general sites and community programs. The evidence-based screenings are there, and involves an automated performance measurement system. We used our computers, includes care coordination and facilitation. So Florida BRITE Project, the SBIRT Grant, as I said, we expanded from 4 sites, 4 counties, up to 65 sites in 19 counties. We screen for risky or problematic use of alcohol, illicit drug, prescription medications, and depression. And these are the providers that we got into. We're in major hospitals in Miami. We're in Veterans Services, the VA Hospital in Jacksonville, and the one in Broward County. And what was nice, getting specialist providers in the aging service, women's services, treatment services, we came up with some unique ideas for SBIRT. The health fairs, they were doing senior centers, senior housing programs, going into county health departments. And the other thing, we had physicians that were doing screenings in the community. They had a large truck that they were doing health screenings anyway, and so we got them involved in providing the screenings for the BRITE Project, along with the other screenings that they were doing already. The general medical providers, we had emergency rooms, trauma centers, urgent care. Urgent care centers are fantastic to get into and do direct contracts with. We had 5 of them over the period of the 5 years. And after the funding was gone, they continued to practice because the doctors that own these urgent care centers says it's the right thing to do. And it's a very simple process when they come in for admission. And I'll go over that. I'll go through this slide real quickly because it basically just shows where we are in Florida, because I want to just talk about the screening tools that you can use and that's really effective with this. It's incorporated in the normal medical and community settings, providing service to older adults. We show them, or we utilize the screening tools as part of extended health care questionnaire, and that's what we call it. When they come in to see the physician, they're not coming in to be screened for drugs and alcohol. But what we do is we explain to them before we even ask them. We tell them that I'm going to be asking you some questions on. It's an extension of your health screening, but it has to deal with substances like alcohol, your prescription medication, even some illicit drugs, because we know that taking these drugs can affect not only your health, but perhaps the prescription or the treatment that the doctor is going to prescribe for you. So it's really important for him to know that. And 99% of the people have no problem with us asking the screening question. In the urgent care centers, they actually incorporate those questions into their application information. When you come in, the patient fills it out. What we use and what's really good to use is the NIAAA. It has the quantity frequency questions, and we use it for the 65 and above. We just use it for 55. As you can see, if they're over that amount that's on there, over the 7, or the maximum drinks of 3 for women and individuals 55 and above, if it's 3, then we complete the assist. And if they score on the questions for depression, we will also do that. As you can see, the part 2 of the 7-question screen that we use, the first 2 questions were developed by Browsing colleague. It has like 93% factor, negative predictive factor, means it's only going to miss 7% of the people. So if they say yes to one of those, we do the assist. Also, if the last 2 questions are from the PHQ-2, which is for depression, it's from the PHQ-9. So those 7 questions can go on a form added to the admission papers to most programs as an extended health questionnaire. As you can see, if they screen yes, we'll go ahead and use the assist. The assist is through the World Health Organization. If they say yes, the BRITE staff also to one of those other 2 questions, the S-GDS. The S-GDS, the Short Version Geriatric Depression Scale, if it's 15 and above scale, we will refer them for a complete assessment. Now, if they come in and they screen positive on the assist, the alcohol questionnaire developed by the World Health Organization, excuse me, and the PHQ-9, or 2 rather, in the S-GDS, we will send them to a co-occurring disorders program that can assess them for both issues. Because our people send them for a complete assessment if they're positive. As you can see, this is the PHQ-2. little interest or pleasure in doing things, feeling down or depressed or hopeless. I'm going to go through a couple of these because I'm running out of time. We need time for questions here. The short version geriatric depression scale for SBIRT is really good for older adults. Approximately 75% of the patients screened positive for substance misuse when we used it. If yes to alcohol or substance and yes to depression, we complete the ASSIST and the S-GDS. Brief interventions are being used. They're about 5 to 10 minute sessions used with the patient. We know that a 5-minute can be just as good as an hour-long session. Consists of the motivational discussion with the patient using motivational interviewing techniques. And basically, we're discussing issues that are focused on increasing the patient's insight to their awareness of the problem. And if they score very high on the ASSIST, they're referred for that complete assessment. We use the motivational techniques. We know people are motivated by money, awards, recognition, but with older adults, health is very important, and to get them motivated because they automatically have a instantaneous referral with a physician. In therapy, they got to come in many sessions before you build up that rapport. But when they come in, they're listening. They want to know what's wrong with them and what they can do to feel better. So health is a good motivator to get to look at their behavior and their use. And this is, again, following a screening score of 2026. We use what we call extensive brief intervention. It's used more with more information about, let me move to, well, screen real quick. To just here, we use more motivational techniques. With them to get them to look at their behavior. Traditional substance abuse and primary care, BRITE services and primary care provide linkages to the substance abuse programs and services. Federally qualified health centers are a good resource. Hospitals, VA hospitals, working with the populations they do. Another specialty services, if you have adult protective services, senior daycare centers, visiting nurse association, mental health programs, veteran services. And these are the individuals that can provide these kind of services, physicians, residents, social workers, counselors. And in Florida, we were supposed to do 66,074 people over the time period. We actually did over 85,000 people in here, and this is basically some of the results. But instead of talking about that real quick because of the time frame, here is the website. All you have to do is go here, and we had just recently, my colleagues and myself had an article published in the American Journal of Public Health. It was, after months long working on this, it was actually published in January of 2015. So this will give you more information on our results of our project with older adults. And we need to continue funding those type of programs for older adults by, we have SBI, the billing codes that were established in 2008, some of you are familiar with those, CPD codes, Medicare codes, and Medicaid codes. The only problem, some states haven't had enough money to turn on their Medicaid codes. Like in Florida, we've had our Medicare codes established, but the Medicaid, the money isn't there for it. As you can see, these are the small fees for it, but other services that you can use are specific grants. After our money left, we use state funding monies for some of our programs. They were able to get local grants through their county funds. Also, we have to apply the SBIRT model to the other populations here in Florida, which we do, 18 and above. There needs to be more service for veterans, and we need to help to find other resources. And one of the resources for treatment we know is the Affordable Care Act. This covers preventive care, so the screenings that you do for someone that does not have insurance can, through your Medicare, Medicaid, and through the Affordable Care Act, you can look for reimbursement for that, especially if they need to be sent for treatment. This is a funding source that can be utilized. People need to be more aware of the Affordable Care Act insurance, and it covers health insurance and mental health services for your older adult population. And Medicare covers a wide range of the mental health and substance use services. And again, for our older adults here in Florida, we use it quite a bit. And here is the definitions of the Affordable Care Act. And you can get this information from CSAT. It's available from the National Clearinghouse, all this information that we've been talking about today on the tip 26, tip 34, tip 35, that were at the bottom of my slide. You can get those there. And also, you can get information about the BRITE Project and working with older adults at these sites. At the BRITE site, University of South Florida hosts the state BRITE website. You'll see a lot of curricula that was developed. A lot of I developed. All of it's free for you to download, to utilize. Also at the National SBIRT ATTC IRETA site, or you can email me at rhphd@embarkmail.com. So I would like to thank you, and I hope that I covered a lot of material in such a short time, but if you have any questions, please do not hesitate to contact me. And I turn it back over to Danielle.
Thank you so much, Dr. Hazlett, and for that great presentation. Now we're going to take a little bit of time and go through some of the great questions that came in. We're going to start. Just a moment, I apologize. So the first that came in, do you know of research of SBIRT being used with a mental health population?
The University of South Florida has been publishing some information. Dr. Larry Schoenfeld, which was a colleague that was working with me on the SBIRT process at the Florida Mental Health Institute, can be reached by going to the website that I put up there for BRITE services. It has Dr. Schoenfeld's name in there, and also information. He can give you what they have, and also lead you to much more information on mental health issues with the older adult. And that's at that brite.fmhi.usf.edu. And again, that's Dr. Lawrence Schoenfeld.
Great. Thank you so much for that response. We have a few others to go through. Next, how do I bring up alcohol abuse with this population?
Well, the best way that we approach them, again, is looking at their health, because they come in, and what we do with the screening, after we screen and they're positive, we get out visual aid that shows the body and shows the different areas, and talking about their use of alcohol and how it can affect their health in those areas, like in the liver area, and show them that the amount that they're using is over what we call the normal limit. And we talk about what the normal limit is, and we give them the education information right away, and then we ask them, well, what do you think about that? Mr. So-and-so or Miss So-and-so. And most of the times they say, I never really thought about it. I thought had no problem with my drinking. And I said, well, as you can see, it can be the problem. I'm not saying that it is right now, but it can be. So it's the way that you approach it, and the best way is in the health relationship, because, again, they go to their physicians or they go to the emergency room. So these are the areas. What we have done in Florida, we have got our certain providers into the emergency rooms. They're not hospital employees. They have a working relationship with that hospital, that memorandum of understandings is what we help develop. And they actually are in the emergency room providing the services for the hospital, and they're screening the patient. And that's why we're finding a lot more patients that have problems than not, because we have those kinds of professionals in those kind of services.
Great, thank you. Next up, we have the question, were BRITE screenings conducted in older adults' homes? Are you aware of screenings being conducted in naturally occurring retirement communities?
Yes, we have services. For example, we have in Broward County, we have the Department of Elders and Veterans Services. They're not only in Tampa General or in Broward General Hospitals, but they are still going into the homes. When doctors are referring them, they still go into the homes. We have the adult protective workers that are going in the homes that administer the screens in those areas. Also, for example, we have a drug and alcohol treatment program, inpatient program, that are actually doing health fairs, and also are going into retirement communities and doing health screens. And part of those health screens, they're using the BRITE, the screening tools to accomplish that part of the screen. And they work with physicians that are doing screening. Some of the programs that we go into, and some states have them, some states don't, are day programs. In Pennsylvania, they have a program where the older adults, the buses pick them up at their homes, they bring them into the program, they spend all day there, they have a recreation therapist working with them, they watch TVs, they play cards, and there's a nursing staff that helps them, that fills their medication boxes. There's a physician that comes in so many days a week, especially if somebody has a health problem. These are great places to incorporate the screening for older adults.
Great, thank you. Next, we do have, what are the most important differences between SBIRT for the general population and SBIRT for older adults, if you had to sum it up?
To summarize, is basically their intake. When you're doing SBIRT 18 and above, their ability to drink more without any health-related problems, or their health is much better than in the older adult population. And that's the biggest thing. When you get older, you cannot drink as much as you can when you were younger because of the metabolic issues, hereditary type issues. Again, it's really tough to pinpoint one thing, but there are several things that delineate between the younger populations and then the older population.
Great, thank you. Next, CPT codes are a challenge as it requires minimum 15 by a small number of approved providers. Any best practices or progress in reimbursements for this?
I know there are a lot of people working on that because they've tied the hands by saying it has to be a licensed mental health person or whatever to provide these services. So it could be a licensed physician or that. So that has created a lot of problems for programs that are utilizing people that have a bachelor's degree that do not have any type of licensure that can qualify for that. They're working on that at state levels. I'm trying to think of the person I know that has been working on it more specifically. I think you know it too. I'm having a senior moment. I know him as well as my own name. Eric is his first name. Anyway, I'll get that information hopefully to Danielle, and she can send it to the person that is asking this specific question. But everyone's working on it. The thing that was very helpful to you that are initiating these in your states is on your steering team. In Pennsylvania, we had someone from Aetna and Blue Cross Blue Shield actually on our steering committee, which helped us when we were looking at the insurance reimbursement for that, for those kind of things. So I think at state level, if you can get your people to work on it, it could be helpful because each state has certain rules where they're doing their Medicare and their Medicaid programs. So I would look to getting some help from that steering committee if you have one.
Great, thank you. Next, the question, does alcohol and depression go hand in hand?
Alcohol and depression go hand in hand. Well, as you can see in the statistics that people that had depression had more substance abuse issues than the normal population. So I would say definitely yes. I think alcohol is so acceptable in that population that some of those people still think that, I don't have a problem and I'm not an alcoholic. I just drink beer and not, alcohol or take drugs. I don't take drugs, so I really don't have a problem. But we're finding with the older adult population, alcohol is one of the #1 drugs. As you can see in those scenarios of the older adult patients that we saw, alcohol, they went to their few drinks in the evening, just a little bit more to help them with their depression and help them with their loneliness. But again, yes, it's more prevalent.
Great, thank you. Next, what do I do if the older adult is lying about their substance abuse?
Oh, that's a big one. The only way around that is, again, what we have done is we ask them to come back, and what we do is a lot of times when we talk to them and they've scored pretty high on their screening tests, part of the responsibility is notifying the physician right then and there. What we do is we have we call them healthcare educators or healthcare advocates. Okay, we go in. We don't say, "Hi." Before I retired, for a lot of years, I was a certified addictions counselor and certified clinical supervisor. And since I retired and looking at my budget, I don't have paying for those services anymore. And I'm not in that field of actually providing direct services in substance abuse. But I don't go in, I never went in when I was mentoring and showing people how to do this. Part of my job was mentoring. I never went and say, "Hey, I'm Dr. Bob. Hazlett, I'm a certified addiction counselor, certified clinical supervisor. I said, I'm Bob, and I'm part of your healthcare team. And we made sure that they don't put licensed mental health on their things because they're not there to see a mental health counselor. They're not there to see a substance abuse counselor. They're there for their health. So we approach it that way. If they're in such denial and it's such a high score, we left the room. We told the nurse, and the doctor would come, and the doctor would help us with the intervention. And he tells them, our educator has informed us, and it's very important for your health, Mr. or Mrs. So-and-so, that you really look at your drinking behavior or whatever it is they're using, and if they don't want to, you can't force them to. But that really helps when the physician gets involved in that intervention, especially in the primary care sector. And it's very difficult if you're not in that kind of atmosphere because all you can do is just use all your skills in the caring and being very sensitive to their feelings and approaching it at the health aspect. It's your health, and I'm just giving you the information because I really care about you, and it's your health is vital. Those are the way that we approach it, and a lot of times, like I said, it works very well, and you're always going to get the one that's not going to work with.
Great, thank you. Next, even though the assessment numbers were favorable, why were referrals for treatment so low?
Because in the primary care, it depends in the areas that you're at, you're going to find a lot of people are way below those limits where they need an intervention. As you can see, the numbers weren't that high, but they were better than not doing it at all. That's the issue. This isn't being done at all. The screenings aren't being done. Some of the I'll give you an example. I've been in this field for a lot of years in the field of addiction, and the cage has been around forever. Some people recommend the cage. I personally would not recommend the cage because the cage was developed a long time ago to look for basically dependent people, so there's, like I said, I wouldn't recommend that screening. But I really feel that the screenings need to be done more in different type of settings and finding more and more people. If we didn't do that, we probably wouldn't have found anybody. And that's why you go into the primary care so that you can find those individuals. Because those individuals, even though they're low numbers, wouldn't have gotten anything if it wasn't for the project.
Great, thank you. Next up, how did you identify appropriate community settings to deliver SBIRT screenings?
Appropriate settings? Well,
yes.
actually, what we did, we looked out into our communities, and we finally got into 19 different county areas. We looked for a higher percentage of older adult populations. We got sites down in Fort Myers where a lot of people retire to. We kind of did our own assessment based on the population area and the services that are in there. It was difficult to get into some of the hospitals, but we did it. It took a lot of patience, a lot of work. Some of the providers, it took us almost a year to get them into those community settings because of either denial by the community or the hospital's looking at that this might be something that's going to create more problems and time consumption in their emergency rooms. But we were able to show them that you don't integrate your process into ours, we just integrate ours into yours and make it part of that. So that's why we developed what we call business process analysis plan. Go into the hospitals and see where the patient goes first, who sees the patient, then who sees the patient after that, so we can incorporate it into that setting. But in the state, we looked at those with the highest population of older adults. And we were lucky to get into, like I said, 28 contracts with 65 sites throughout the state.
Okay, great, thank you. There are so many good questions. Next, is it best to ask these screening questions in person or using a form?
I think I think it all depends on the setting that you have. If you have a lot of time to ask these questions, I think it's good to ask them, the interview type. If you don't, I'll give you an example. A lot of hospitals have to go through the process with their internal boards, and the paperwork is uncomfortable for them. Where other programs like urgent cares, they just made it on, put the screening questions on their forms. When you have it on a health-related form, they're quicker to answer that than if you have a separate form asking, we're going to be asking you about your substance use. If you make it part of that healthcare questionnaire, it's much easier to get people to be more honest with you. And so there, like I said, there's pros and cons for both. I'd like, if you're going into the homes, again, you know, you're going in to do other services, so it'd be better to do the process of asking them the question. But you know, that's just the way that we've done it here, and I think the questionnaires I'll give you a good example. One of the sites did a group health. He was a nurse. He was doing a health presentation at a retirement community in the day room, and she handed the form out. Okay, it's part of the health square, and they filled it out. And as they turned it in, she looked at them very quickly at those questions, and she just asked the person, "Would you mind if I come back and visit with you at another time?" And I said, "Oh, no problem." So then she would go back, and then she would complete the screen, the full screen, if the pre-screen was answered in a positive way. So I hope I answered that question.
Thank you. Next, is BRITE being used in any other states besides Florida?
Yes, some states are trying to get it. They contacted me. I've worked with about 5 other states that have written their grants to include the older adult population. And the one that I am working with now is in the University of Louisiana State University School of Social Work is trying to implement the SBIRT in their state, and they're hoping to get one of the upcoming SAMHSA grants. Another program was in, Oklahoma. So, you know, there's a few states that are looking at that population. A lot of states have gone from the 18 and above down to working also with the adolescent population.
Okay. Great, thank you. Next,
Other states also too I've worked with that is doing this is Virginia.
Okay, great information. Thank you. Next, what screening tools would you use to assess for prescription drug abuse?
Okay, there isn't anything out there really that's better than I feel the assist. Because part of the assist, if you look at it, pull it up on the website, has on there that you ask the patient about their use of prescription medication. The dialogue is that if you have used any prescription medication for any use other than what the doctor prescribed for you, or in an amount larger or lesser than the doctor prescribed for you, please let me know about that. And there's a section on it where you can annotate the drugs, the prescription medication that they're using. There's no other one that actually asks about prescription medication that I know of at this point. I know that some are working on that, and I know Dr. Shanta and myself, we're talking about working on something that we can put out there and get tested, but there isn't a lot, especially for just misuse. And I would recommend the assist.
Okay, thank you. Next up, what are the healthy drinking limits for this population?
Healthy drinking limits, again, it's for actually women or men that are 55 and above. We use the one from NIAAA for the 65 and above. We go to no more than 7 drinks in a week's time, and no more than 3 drinks at one setting for the older adult population. And if they're using more than that, all it does is that puts them at risk for health-related problems, and that's where the brief interventions go. Those are the feedback that we give them. We give them the simple advice and show them how it can affect their health. And if you look at the one slide on there, it will have that information for you, the 7 and the 3 on the screening tool.
Great, thank you. Next we have, are there any special procedures for establishing trust with this population?
I think the best techniques that I found is making sure that you're sincere in your presentation and that you show caring. And a lot of times, the older adults that you work with, you're the only contact sometimes. I mean, they welcome the contact. They welcome talking to you between while the physician, because a lot of times when you go in there, you're standing there for 10 or 15 minutes waiting for the physician to come in and having someone there to talk to. It's like every tool that's out there. It's only as effective as the person delivering the services or that tool. When you're listening to them, when you're showing them that you really care and you're very sincere, that to me has been the best way to reach this population. And a lot of times that they come back just to have a conversation. And it's a shame. Sometimes they use the emergency room because that's their only alternative and in touch with other people. They get a lot of attention when they come in. Again, that's to me, it's how you use these techniques and how you deliver them to the patient or the client. Sincerity, honesty, and a caring attitude will do it. And I've had to mentor some really tough nurses that had the med-surg nurse, attitude. On the med-surg, you need to take your med. You can't approach them with that type of an attitude. So we had to do some training to get the person to understand their tone and their voice, how they approach the person. But the honesty, sincerity, and caring is the key factors rather.
That's great. Thank you. Now we have time for just one more question.
Okay.
This one. Do you have any tips to use for the brief intervention for this population?
Any tips? I think the best tip is walking in with a smile on your face and shaking their hand, say, "Hi, how you doing? I'm I'm part of the team here, and how are you doing today?" Well, most of them say I'm not doing very well because, again, it's your approach to them. Just by your smile and that friendly introduction. And sometimes when you start talking to them, it really helps take their mind off of it. If somebody's in severe pain that needs to see the doctor right away, you're not going to be dealing with those type. They're going to be seen by the doctor right away, but you're going to be seeing other individuals that might have some minor pain, and you get their mind off of it. It's very helpful. But my tip is I've never had a problem when I walked in and gave them a smile and a friendly handshake and let them know that I'm concerned about their health and why they're there. That's my tip.
That's great. Thank you. Applicable to anything and everything, I think. A smile.
Yeah, basically, you're right.
So thank you so much for taking the time to answer those questions. I think that is the last we had time for. Okay, at this point, I'd just like to briefly remind you that the PowerPoint slides are available at the website, as well as the recording will be available shortly. This is also where the CE quiz is, so we can process those CEs for you, those free CEs. Additionally, I want to point out that we do have a survey that we ask you to complete. I can't emphasize enough how important this is to our funding, and we'd like to hear what you think of the training. Now, that information, Misty did put it in the chat window, the links to that survey, as well as some other informational links. Okay, and it's also available at the bottom of this page, this PowerPoint. Okay, and this is just further information as far as our upcoming webinar series, things we've done previously and subjects coming up. Okay, at this point I want to thank our presenter, Dr. Hazlett. Thank you so much for the presentation. It was great, and we thank everyone from our partners. Thank you for attending today.
Thank you. Are you still there, Danielle?